Okay, so once you've made your diagnosis of acute kidney injury, the first thing you're going to do is get the urea-creatinine ratio, also known as the Bun-creatinine ratio. And it's going to be one of three things. Either it's going to be normal, which is more than 20 to 1. That's your Bun-creatinine ratio. Or it's going to be abnormal or very abnormal, but we'll come to that in a minute. So if it's normal, then our problem is going to be a pre-renal problem. So let's quickly draw out the nephron so that we can illustrate this. We've got our heart, which pumps blood to the kidneys. Let's quickly draw out a nephron. That's our loop of Henle. The PCT, proximal convoluted tubule, distal convoluted tubule, which empties into the collecting duct. That passes into the bladder, which has two ureters, and then comes out through the urethra. That's a very basic picture of the nephron. Now, pre-renal is a problem from the heart to the glomerulus. And there are four ways actually that you can get this. Number one is the OSIS, O-S-I-S, which is gastrosis, nephrosis, renal artery stenosis, and cirrhosis. The next cause is the 4 Ds: diarrhea, diuresis, dehydration, and hemorrhage. The next cause is there's something wrong with the pump. That can either be an MI or heart failure. And the last problem that we can get is a drug problem. Most commonly your NSAIDs or your ACE inhibitors. So NSAIDs will affect this end, ACE inhibitors will affect this end. So the NSAIDs cause vasoconstriction here, the ACE inhibitors cause vasodilation here. And that leads to less blood going through the glomerulus. Right, that's pre-renal. Now let's move on to intrarenal. This is the hardest part. And then we'll touch on post-renal down here. So in intrarenal, your renal function is going to be significantly impaired. So your Bun-creatinine ratio is going to be much lower. Normally, it's going to be less than 10 to 1. Between 10 and 20 to 1 is going to be post-renal. So that's 10 to 20 to 1, Bun-creatinine ratio. So once you've worked out that you've got a Bun-creatinine ratio of less than 10 to 1, you know what's going to be an intrarenal cause. The next thing you want to do is order two things: urinalysis and urine microscopy. And the urine microscopy is going to return your cast, and it's going to show one of three things. So I'll show you the three things that can go wrong for intrarenal. Number one is a problem in the glomerulus. That's here. Number two is that we can have a problem in the tubules. And number three is we can get a problem in the interstitium, this area here. So you're going to order your urine microscopy and you're going to get back your casts. The casts are going to show one of three things. Either you've got a glomerular problem and you're going to get red blood cell casts. or you're going to get a tubular problem and you're going to get muddy brown casts. Or finally, you're going to get an interstitial problem, and that's going to show white blood cell casts or eosinophils, and eosinophils. Alright, so what are the causes of these three different types? Let's start off with the glomerulus. So there's two categories. There's post-infectious and there's two types of post-infectious. The first one is going to be your post-streptococcal glomerulonephritis. This is going to be your child who has a sore throat. 1 to 4 weeks later, they start having blood in their urine. That's post-strep glomerulonephritis. Then the second one is what's called Berger's disease or IgA nephritis. Now, this is going to occur in your young person who has an upper respiratory tract infection. 2 to 4 days later, they get blood in their urine. So the difference between these two is this is 2 to 4 days after an infection. This is 1 to 4 weeks. That's how you can tell them apart clinically. The second category of glomerular problems is vasculitis. And there's 4 things I want you to remember here. First of all, lupus. You diagnose that one based on history, so look for classic signs of lupus like the malar butterfly rash. But if you need to do a diagnostic test, do the double-stranded DNA. The second one is Henoch-Schönlein purpura, HSP. It's also known as IgA vasculitis. Very similar to IgA nephritis. The problem is with the IgA, except IgA vasculitis affects the whole body, and IgA nephritis affects only the nephron. And you can diagnose that one based on C-ANCA. You diagnose that one usually based clinically, but if you can't make the diagnosis on clinical features, then you should do a renal biopsy. The next cause is granulomatosis with polyangiitis, GPA, also known as Wegener's disease. So this patient's going to have granulomas in the lung, and they're going to have blood in their urine. The last one is Goodpasture's disease. This is a condition where you have antibodies against your GBM, and this patient's going to be coughing up blood or have pulmonary hemorrhage, and they're also going to have blood in their urine. To diagnose this one, you need to do 3 things. Number 1, order C-ANCA. Number 2 is to order a renal biopsy. And number 3 is to get your anti-GBM antibodies in the blood. Alright, that's the glomerular problems covered. Let's move on to our tubular problems now. So again, we have 2 causes. The first one is ischemia. And the second one is drugs. So we get this problem when there's either not enough blood coming to these cells that line the tubules, or there's toxins that are killing these tubules. Then these epithelial cells fall off and they pass out in the urine as muddy brown casts. So the ischemic one, that's from not enough blood coming through. That can be from, that can be related to some of our pre-renal causes. The drugs one, there's a few drugs here that you should try and remember that can cause acute tubular necrosis, ATN. They are gentamicin and all your aminoglycosides, amphotericin, contrast, used in CT scans, cisplatin, an anti-cancer agent, myoglobin, seen in rhabdomyolysis, and look for myoglobin casts. And lastly, hemoglobin, seen in hemolytic anemia. Alright, there are even more than those that I've mentioned, but they're the main ones and they're the ones that I want you to remember. Okay, now let's move on to our interstitial problem, the last part of our intrarenal causes. So again, we have two causes. The first one is drugs. Now, this list is huge. All your beta-lactams, amphotericin, NSAIDs, sorry, we've got NSAIDs up here as well, actually. There is a very long list for the drugs under interstitial. I don't want you to remember them because the list is so huge. Instead, remember this list, and if it's not part of this list, it's going to be an interstitial problem. There's no point trying to remember that huge list of drugs. And the other cause of interstitial problem, the other category of interstitial problems, is Sjögren's syndrome or pyelonephritis. Alright, that's our intrarenal causes covered. Now let's move on to the easiest part. This is our post-renal causes. Now this is going to be an obstruction. So the obstruction can be here or here. And the obstruction is either going to be a stone or a tumour. So this includes your kidney stones, urethral stones, or your tumours that can occur here, including benign prostatic hypertrophy. So look out for stones or tumours.